Hello and welcome to this next episode of Grow Conversations. My name is Alex Fraser and I'm your host on this, your window into the world of medical cannabis in the United Kingdom. And on today's show, we have a researcher at Nottingham University, a PhD in pharmacology, Stephen Alexander. Stephen, welcome to the show.
Thanks for the invite, Alex.
Really glad to have you here and really looking forward to getting stuck into a little bit about the work that you do and the endocannabinoid system and having a better understanding a little bit of how that works for our viewers by the end of the show. But I think, to start off with, perhaps you can give us some idea of your sort of background and how you've come to be working in this field.
From background, I'm a sort of biochemical pharmacologist, which means I like to figure out mechanisms of things, and particularly molecular mechanisms of drugs. So I've had a career which has looked at a variety of different natural products, including caffeine. But around about 25 years ago, we got interested in the endocannabinoids because it was around about that time that the first endocannabinoid was identified, an andamide. And a colleague in the School of Pharmacy across the way from us identified how easy it was to synthesize in the laboratory. And so he came to us and said, well, we can produce this, so would you like to test it? And that began the sort of cycle of initially starting off with the sort of enzymology of the endocannabinoid system and then looking at the receptors and through various collaborations, getting involved in a whole variety of different things, from plant cannabinoids all the way through to the ways in which physiological and pathological regulation of the endocannabinoid system might be exploitable for therapeutic benefit. So going all the way from molecular aspects of enzymes and receptors that we put into model cells all the way through to humans.
Brilliant. Well, obviously we're coming from that very pharmacy sort of side of things on this podcast and trying to understand sort of implications for patients, for people with different symptoms, and for sort of understanding this system in the body and how that actually works in practice. So I guess it's a lot of linking that back up. And obviously we're very focused on plant-derived cannabinoids, phytocannabinoids, and perhaps that's something we can before we go into more detail in the endocannabinoid system and different things that it does. Maybe I'd be really interested in your thoughts about, I guess it's the nomenclature, it's how it's been named, and the fact that this sort of comes from the plant rather than the other way around, and it's to do with the fact that we discovered cannabis, then cannabinoids, and then the cannabinoid system. But actually, the endocannabinoid system really isn't connected to the plant, and it just happens to be a plant that produces a lot of these chemicals.
It's really an oddity of the system that of the 110 plus unique metabolites in the cannabis plant, really only very few of them do we know precisely what they do pharmacologically. And when I say precisely, we might come back and see that it's not that precise at all. But a very modest few, 2, maybe 3, actually interact directly with the endocannabinoid system. So much of what we know about THC is because of its targeting of CB1 and CB2 receptors, these molecular targets. And that's true for the endocannabinoid system as well. But for the remainder of the metabolites from the plant, very few of them have the same behavioral effects in terms of the classic sort of high and dope, the extended period of dissociation from the environment. And so it's actually only a small fraction of those plant cannabinoids that interact with the endocannabinoid system in a way that we understand. So I think there's a lot of interest in how the other metabolites, things like cannabigerol and even the acids, THCA, for instance, and so on, may function, but it doesn't seem to be through the established endocannabinoid system. It doesn't mean they're not interesting, they're just interesting in a different way.
There's other receptors doing slightly different things, isn't it?
Probably. So, for cannabidiol, which we've known about for longer than THC in a certain chemical sense, we still haven't figured out exactly how it works. There is an indirect interaction with the endocannabinoid system that we can identify, but it's not a direct one in the same way as THC functions. So there's a lot of hints about how it might work. And I think one of the most attractive hypotheses is that it actually works through modest adjustments of multiple targets. And so one of the things that we find with an awful lot of drugs is if they're too effective in a single pathway, you get a natural physiological response which kind of reverses that, and you get a sort of a washback which is unhelpful, or an adjustment. And we don't seem to see that with CBD. And that's possibly because it's multiple subtle effects, each of which kind of works together to synergize to do some of the beneficial things that we can see, without necessarily being aggressive, powerful, overactive in any one pathway.
And is that perhaps why we see it as being such a useful medicine in a lot of ways, because it doesn't have quite so severe effects? In that sense, it's quite mild in its actions.
Yeah, so I think, you know, a lot of the stuff about CBD is yet to be proven. There are some good pointers as to how it might be beneficial, but I think one of the things that's really difficult to find is some negative effects associated with CBD. So in the clinical trials where CBD has been used for treating seizures, there are side effects, but they're the sort of modest side effects that you see with many orally administered drugs. So stomach upsets and GI gastrointestinal upsets, which is really very common. And that was at reasonably high doses, you know, in comparison with many other drugs. So there are small reports, modest small reports. There are a couple of reports of adverse effects of cannabidiol in non-human systems, which haven't, as far as we can tell, translated into the humans at the moment. So by far and large, CBD seems to be a fairly non-destructive, non-damaging element. Now, to get to the stage of being more positive about its beneficial effects, we've got clues. Clearly, in particular types of epilepsy, it is effective. There's very good evidence for positive impact on things like anxiety and sleep. And there's lots of indications for other things. And I think there's some really interesting things which are, I suppose, maybe slightly off mainstream, things like wound healing as a sort of superficial, you know, administration. But these have yet to be tested in a way that clinicians would accept as being rigorous and systematic, and so would allow a licensing capacity, for example.
Yeah, and that's why we are where we are with the sort of legal access in the UK, very sort of prevalent on the unlicensed side for, you know, different things, but without any, you know, hugely concrete evidence in a lot of different areas. And then on the legal side, we have things like Epidiolex for seizures because of those clinical trials that you mentioned. And I guess this is an important point to touch on, is sort of the understanding of where we are in our understanding of sort of the impact of those cannabinoids. But before we go too much into that, I sort of want to take a little step back, because I do know that some of our viewers aren't necessarily as scientifically minded as perhaps yourself, and certainly I'm one of them. So perhaps you can. I was hoping that. So I have a certain ways that I describe the endocannabinoid system. I'm sure they're not 100% accurate. How do you describe it to someone who perhaps is not a scientist?
So the way I try and get it across is that the endocannabinoid system, and most of what we know about it, is focused on nerve cells. It's not exclusively there. In fact, it's almost impossible to find an organ in the body where the endocannabinoid system doesn't have a function. But the one that we know most about is in nerve cells. And the way it tends to function there is a sort of braking mechanism to try and prevent overactivation. So when you've got what could be an external force, damage, things like inflammation, infection, what we tend to see is an accommodation of the endocannabinoid system that allows a reduction of the impact. So we've got these two receptors that the endocannabinoid system targets the CB1, which is mostly in the brain and nervous system, not exclusively. The CB2, which is mostly associated with immune cells and the regulation of immune responses, but will be induced, so it does actually increase its levels of expression in response to damage. So a lot of what we're seeing with the endocannabinoid system is a calming response to excess or stress or inflammation. And so it's a way, in a very local response, because these things don't go very far. They don't, they're not like hormones. Adrenaline, for instance, producing the adrenal gland, goes through the entire bloodstream, hits the heart, hits the lungs, hits the skin, all those things. These are very, very limited in the sphere of influence. And so they're very specific in terms of which pathways they can regulate. So there's a mechanism there for prevention of damage.
Talking to patients and talking in a practical sense, there, I mean, evidently seems to be very different types of pain, and it does feel like cannabinoids do play a role in various different types of pain. And I'd sort of probably quite naively separate these out into essentially nociceptive action, which is sort of calming stimulation of nerve sort of impulses, and then on the other side, this inflammation action, which is you describe it as calming, which I think is perfect, and it's that you know, the overactive response of the immune system, perhaps.
So I think from a physician perspective, there's ways of differentiating multiple types of pain. A pharmacologist would also look at how you might be able to exploit that difference for benefit by targeting different systems, whether it's opiates, whether it's using the non-steroidal anti-inflammatories, the ibuprofen and agents like that, or for instance, cannabis-related medicines. And that's really because of, you know, we were talking earlier about the sort of complexity of the cannabis plant. And that's a positive and a negative. But when you look at the combination of different cannabis types and what has been done to identify potential benefits in different clinical indications, one of the ones that comes to the strongest is pain. And it's still a bit vague and not so nailed down as one would like, because there is a huge variation in cannabis from different sources, not just geographically across the world, but you know, within different suppliers, whether legal or not, and the way in which people take it, the doses they can get in. So it's a really kind of a difficult one to actually achieve the sort of clinical significance that one would hope in order to convince people that licensing would be a good thing.
That's, I mean, yeah, you're hitting on something that is really at the crux of the conversation around medical cannabis in the UK, which is licensing essentially, and being able to develop the evidence to the extent that will convince regulatory bodies to do so. And perhaps with cannabis, this isn't going to fit into the models that we currently have.
Yeah, so I mean, there's many things that have kind of got in the way a little bit. So one of the things that should assist is the introduction of standardized preparations. So clearly, to have something that you're confident what the content is in a reproducible way, and you can analyze people's responses to the same thing given in the same way at the same time of day for a given period of time, that will give you confidence that anything that you see is a genuine effect of that agent. Whereas, of course, you know, worldwide, there's a huge variation. So the change in the law in November 2018 was actually really significant in terms of allowing not so much the clinical trials to take place, because they could have taken place beforehand, but the barriers that there are in terms of setting up trials with a Schedule I substance is really difficult. And so in reality, the United Kingdom has kind of taken a lead in trying to get clinical trials together of cannabis-based medicines. Because despite things like legalization in different countries across the world, there hasn't been the will, the capacity to produce these clinical trials which would give evidence or not, potentially, as to the benefit, clinical efficacy of cannabinoids. And so, that was a really interesting starting point. The National Institutes of Health Research that were looking after the clinical trials, finding ways of funding those clinical trials, setting them in motion. I think they were still in the recruiting phase as the coronavirus pandemic hit. So I suspect very few of those have continued. The only ones I think that may well have continued are things like the epilepsy, where there's a much more severe outcome if that was stopped.
Yeah, I mean, and it's tragic, isn't it, really? Because it feels like, speaking to patients, there's a lot of impatience, should we say, for sort of developing NHS access, which, I understand if you're not well and you're in a financial position where going to the private system isn't an option, then I understand that frustration. At the same time, it's been 2 years since the law change, and that might sound like a very long time to someone who's suffering from chronic pain, and I know what that's like personally, but in research terms, 2 years is a very short amount of time. It takes a long time just to get funding for a trial, let alone to put it in place and to have everything, and then to even get results from it. You're talking, well, maybe you can give us an idea of sort of the timeframes involved. I mean,
well, yeah. So a typical clinical trial, you're usually talking about 2 years, and it depends really what the problem is that you're investigating. But it would be an incredibly efficient version to be anything shorter than that. So, in comparison, when people are talking about the vaccine for the coronavirus, and talking about, I think we're starting in May, maybe June, and having an outcome early next year, that's really very, very fast. And that's not the typical pace. And of course, coronavirus is an exception. So that the organization, the application for the clinical trial, getting the funding, finding the right locations for these, because often what you're trying to do is get multiple centers around the country and ideally around the world to coordinate with those. Getting the right dosage forms, the right placebos, because one of the things that's really difficult in the cannabinoid area is getting a placebo that is not obvious.
Yeah.
Recruiting suitable candidates, and then going through the whole analysis of the clinical efficacy. It does take a time, and it, usually 2 years, but more often than not, a longer time period than that.
And
that's a kind of classical version. So, yeah.
With everything that's going on, potentially considerably longer.
Yeah. So, because I'm not involved in any of those clinical trials, I'm not absolutely clear what's going on. But I'd be surprised if many of them wouldn't have to restart from scratch. So an awful lot of the people will have signed up and say, yes, I'm happy to take part. But they may have to go from the starting point again to ensure they've got a suitably validated mechanism.
Yeah.
So, yeah, with the best one in the world, I suspect a lot of these will not start to kick in again until next year.
So patients will be looking for a little bit longer, basically, is what you're saying. Not to put you on the spot, but it's the reality of the issue.
I couldn't say for sure. Well, certainly there are still things ongoing with the childhood epilepsy.
Yes.
But
would you say that's looking quite promising? Sorry to interrupt.
Yeah. So I'm not quite sure when they actually will announce their results. And again, there's obviously been delays and limitations to their studies. But I believe from what I've heard elsewhere that very few of those clinical trials actually have been running in the intervening 8 months or so.
Well, I mean, I guess it's something that we'll have to sort of keep tabs on, and maybe we can check in a few months or so, maybe 6 months down the line, and see if things have kicked off again and where we are then. And, hopefully things will start moving again towards the beginning of next year. Um, I guess something else that I'm really interested to talk about, I was looking at some of the other research that you've done, and particularly looking at sort of mental health. And I know you did some work with, it's the striatum, isn't it? A certain part of the brain. And excuse me if I get this wrong, dopaminergic responses. It's to do with pleasure
Yeah,
responses and addiction and things like that, and the cannabinoid system's role there.
yeah. So the kind of reward system and anticipation of reward deals with a part of the brain called the nucleus accumbens. So this is relatively small in terms of brain size, bit of the brain which is very rich in dopamine. And when we monitor levels of dopamine in that region, we can see that there's a big kick of dopamine that is associated with things that we think are positive, whether that's palatable food, nice food, whether that's sex, whether that's drugs of abuse. In some people, it's gambling. So there are things that we associate with pleasure, but also addiction. Mm-hmm. So there is that real association there. And the endocannabinoid system has a key role in that pathway. So the agent that was used to block the cannabinoid receptor, the CB1 receptor, rimonabant, that was licensed for a short time in the 2007, 2008, was intended and was actually reasonably successful in terms of treating obesity. And the way in which that was interpreted was that it kind of had two actions, one peripherally outside of the brain and one in the brain, and probably in the nucleus accumbens. So reducing that desire for palatable food, so you weren't wanting to go and gorge on chocolate and things. And that, one of the indications that would have continued had rimonabant remained in the clinic was likely to be the treatment of smoking cessation, so kicking cigarette smoking, which for many people is a surrogate of other addictive tendencies. So the anticipation that blocking the cannabinoid system can reduce the sort of highs associated with a variety of stimuli. I think that's a nice, logical package. But of course, rimonabant was withdrawn because a number of the people who were taking it reported really serious depressive events to the level of suicidal ideation. And Sanofi, who are the company who produced it, decided that it was much better to withdraw it. So the possibility that the CB1 and the endocannabinoid system in that part of the brain is a fundamental mediator of reward, addiction, in whatever sort of physiological sense, I think is a really attractive one. But we haven't got to the stage where we can say, okay, maybe that helps to explain why an observation is that fewer people die from opioid overdose in those states in the US where cannabis is more readily obtainable. It's still a pattern that is yet to be, I think, from my understanding, completely identified and resolved. But possibly that's part of it, that you've got a kind of swapping of things which give you that reward, and maybe a milder version which is less destructive.
But is that essentially what's happening there, in that it's not actually being utilized as a, or in that sense, cannabinoids or phytocannabinoids, THC and CBD, aren't being used as an aid for withdrawal. What they're actually being used for is almost a replacement, as a source of pleasure that is not so harmful to the body.
So probably it's multifactorial. So it's almost never a single thing that's going on. So part of it is that you get a little bit of a buzz out of it, and so you're replacing with more aggressive, unpleasant, and ultimately potentially lethal version of a stimulus with another. One of the things that's very different about most of the cannabinoids is that they hang around in the body for longer. So the withdrawal from opiates is an issue because they're relatively rapidly removed from the body, and so you feel that loss of the drug a bit more rapidly. THC and CBD have extended times in the body, and so we get a much slower decline, much more gradual effect, and so you acclimatize more to the absence, I guess. It's a nice hypothesis, and I think it's probably partly true. And then there are multiple other things as well, that you've got some pain relief that you'll get from THC in particular, and so you won't have that need for necessarily the stronger event. It's really difficult to pick these things apart in humans. Humans are complicated entities, and quite likely it's all of those things, and possibly even a couple more where the complications arise.
That's fascinating. Yeah, like I say, it seems to be a topic of a lot of focus at the moment, at least in the UK with the medical side of things. I think primarily because we're looking at avoiding our own opiate epidemic, like the US has had. And then also I think because there's a lot of association with cannabis as being addictive. And obviously I think it's very interesting when you say that we can treat addiction with cannabis, but also we've got a lot of people saying, well, actually it is addictive itself. So yeah. I mean, and that's a risk. There's a controversy there, isn't there, I suppose?
Absolutely. So I think, there's a sort of proportion that people quote based on a couple of decent studies that heavy cannabis users, and heavy is really difficult to be precise about because there's quite a lot of variation there. But heavy chronic cannabis users, probably around about 10% of those are what we would describe as addicted. Now, clearly the impact of that of addiction can vary depending on the drug and the circumstances of the individual. So what that means for a cannabis addict is that there's a good chance of a use disorder of things which are detrimental associated with that, and that's almost always mental health issues, but not exclusively. And how we then decide that can be treated is difficult. And with most addictions, it's a sort of multiple approaches. There's psychiatric support, a family environment which helps incredibly, and most importantly, a desire on the individual to change. So in general, what we find clearly is that there is a big difference between the damage that is done with opiates compared to cannabis. And so for many people, they see cannabis as a much more acceptable alternative to opiates. And if you look crudely at things like deaths in the England and Wales and the statistics that are provided by the Office for National Statistics, there's a very obvious step between the number of people who describe themselves as taking cannabis on a regular basis and opiates on a regular basis, and the number of deaths between the two. So that's that anybody can get because the UK government publishes them.
You mentioned mental health. I think that's really interesting sort of area to focus on, and obviously in the UK we've got a particular focus on that around cannabis and mental health and schizophrenia, and it's something that comes up in the headlines and tabloid newspapers again and again as reasons why it should be kept illegal or perhaps not issued as a medicine. Where do you stand on that? I know you've done a little bit of research into schizophrenia.
So I'll admit before I expand a bit further, I'm sitting on the fence a little bit.
Sure.
So there is a logic to the idea that early cannabis exposure could lead to an increased risk of psychosis. So schizophrenia is one of the more common mental health disorders. It's most commonly diagnosed in the teenage years, more frequent in boys compared to girls. It's more frequent in immigrant populations rather than sort of resident populations, and that's true anywhere in the world. And so it comes out at close to 1% of the population seems to have this, and it's a scale, and it's probably not a single disorder. I think, you know, for psychiatrists, they would subclassify it into a lot of different disorders because there's a spectrum that goes on there. So there is a logic at the sort of time period when the brain is still plastic and still vulnerable, that exposure to any psychoactive substance could be potentially damaging, and chronic high dose exposure to any psychoactive substance, and that's alcohol or cannabinoids or any of the other major psychoactive agents, is going to change the plasticity of the brain, and it may be that then results in something detrimental enough that it's externalized as psychosis and schizophrenia. Because that age group is an age group of exploration. You know, teenage years is when the sort of rebellion kicks in and you start to find out what your limits are, and you sometimes exceed your externally defined limits, and so you test yourself against things that you wouldn't ordinarily be allowed to. And so that there's a logic to that thought process.
Yeah.
So the brain stays plastic until sort of early 20s, and some people would say 24, 25. So anything that externally changes the way in which those, and when I say plastic, I mean, you know, literally there are changes in the directions in which nerves will go. You'll see morphological changes as an adaptation to a variety of external stimuli. So there is a logic there. 10 years ago, you'd have looked around the world and said, this level of schizophrenia is common just about in every country. But we see areas where cannabis use is much higher than in others.
Yeah.
So you'd have said, well, there isn't that association then, so it can't be a trigger. But of course, one of the things that's happened in the last decade, 15 years or so, is that the types of cannabis which are available on the street have changed not just potency of THC, but the spectrum of other cannabinoids as well. And so the higher dose of THC, things which are vaguely described as skunk, may actually be more detrimental. And again, there's this logic that it's not just the THC, but it's also the lack of other cannabinoids and potentially cannabidiol being a sort of an ameliorative, you know, a reducing agent in comparison with the THC. Maybe that balance is something that's been lost.
Yeah. It's interesting you bring that up. I've had that theory for a long time, that it's not necessarily high levels of THC that are the problem, but it's actually that there's a balancing going on between THC, CBD, and maybe other
Yeah,
compounds
I
as
mean,
well.
it's difficult to know how real that is. There are nice studies which have attempted to look at that in humans, and there seems to be some outputs that you're looking at, in some readouts, there seems to be some validity to that. For a long time, it was suggested that maybe it was an interaction at the level of metabolism of the two agents, and that, you know, you would reduce the production of other active metabolites of THC if CBD is present. And if it's not there, then more of that is made, and maybe that's more damaging. But at the moment, we don't know for sure. I think that there's a lot of attractive hypotheses to explain things, but many of these are really kind of difficult to pick apart. I think when I talk to a few psychiatrists, it does seem that they're seeing more people with cannabis-associated mental health issues, many of which are obvious as psychosis, but there's also sort of depressive incidents which are associated with long-term cannabis use and may even be resolved with discontinuation. So stopping the source seems to kind of correct that imbalance. But you could see that sort of pattern being repeated with many psychoactive substances. You know, alcohol is a more significant public health issue in the UK, and has significant mental health issues associated with it.
I don't think anyone's disagreeing with you on that particular.
Yeah. And people might argue more significant social issues in terms of kind of secondary impacts of what goes on in most big cities on a Friday and Saturday night.
Yeah. I lived in Brighton for 10 years and I can tell you all about it, but perhaps on another call sometime. I'm interested, just before we move on, just because you mentioned something that I've stuck in my head now. You mentioned that people immigrating to the country or to any country have a higher rate of schizophrenia. I'd never heard that before. I'm just wondering if you know why.
So many people describe schizophrenia as a neurodevelopmental problem. Mm-hmm. So in that period where there's the spike in the number of diagnoses, it's very often associated with people who've moved in recent history, or who are first generation, second generation immigrants. And it seems to be true irrespective of which country. And when people try and it's a mental health disorder which is really very, very difficult to try and model in experimental animals and rats. But one of the things you can do is kind of separate young animals for even a short period of time from their mothers for an hour a day. And when they grow up to be adults, they have at least one, maybe two or three features which are characteristic of human schizophrenics. Now, these clearly are not schizophrenic animals because we're incredibly more complicated than that. But there are features there which respond to the drugs that people are given to try and treat the schizophrenia. And so it's that sort of disruption of an early period in life which may put you at risk for mental health disorders later on. And probably it's a combination of environment and multiple genes. It's not a simple, there are very few mental health disorders which are easy to describe because they're nebulous and very complicated and probably multiple inputs which lead to that behavioral change.
That's interesting. And it sounds like, I went to a talk from Dr. Gabor Mate. He's a Spanish doctor, talks about depression a lot and talks about the importance of stability essentially during those formative years, having a place where you feel at home, even if it's not specifically your sort of family home, and then having a family around you, again, not even specifically blood family, blood relatives, but having a group that you feel at home in, I guess.
So I think that there's a sort of a benefit of security, which probably puts at risk a variety of things that many of us would take for granted. And so that can, not simply that, but in combination with other events, and they may be drug type things, or they may be further environmental factors, lead to more severe mental health disorders later on.
And might explain why we're seeing such an uptick in the current situation with things like lockdown, separating us from loved ones, separating us from family homes perhaps, and locking down in other places, and why that's causing so many issues for people. So.
Yeah, I think there are so many factors within lockdown, the separation, the lack of contact, which is going to have knock-on effects for some time. it's kind of an oddity, but the joy of actually seeing people in real life is something you took for granted in January and February. But even people that you weren't necessarily that close to actually see them and speak to them in real life is a positive benefit. Yeah.
Absolutely, and we've had a few conversations now over Zoom, and yeah, it'd be lovely to have a pint in real life with you one day soon. But when it's safe to do so, I suppose. And it's something that I know everyone watching this will be able to appreciate, and I guess it's a sort of wait and see sort of moment for us at the moment. So, but we are diverging slightly away from cannabinoids and cannabis onto current topics, and certainly do want to quiz you on a few more things before I let you go. I know that you've done some work with or supported by the Wellcome Trust on and I know that they're very focused on sort of antibiotic properties and developing new antibiotics. And I know that there's some interest with I think it's particularly, you mentioned cannabigerol earlier, but is it CBG and CBC as well that are sort of showing some promise, at least in this area? And I wonder whether you can comment on that.
So to be honest, some of this stuff is actually quite old. And one of the sort of earlier stuff that was going on in the 70s is people were beginning to isolate close to pure cannabinoids. Things have moved on with the chemistry as well to get a bit more quantities of these things and in a lot greater purity. But there have been hints for antibacterial and potentially antiviral actions of a number of sort of cannabinoid preparations. Now, whether that necessarily translates into something that could be useful for humans is difficult to tell. And one of the potential interpretations of why, cannabinoids are expensive to make for the plant. Why would they bother if the plant doesn't actually need them for survival? Why does the plant make all these metabolites? These are really kind of intricate metabolic pathways, enzymes which are not expressed by the vast majority of plants. It's very difficult to find anything elsewhere in the plant kingdom that looks anything like these cannabinoids in the detail that we have and the complexity that we have in the plant. So why does the plant produce them? There must be some benefit. It's a bit specious because they just are, but we would like to think there is a benefit to the plant to produce these. And one of the hypotheses is that these are a kind of a plant version of an immune system. So clearly plants don't have B cells and T cells that produce antibodies and fight infection. So maybe producing these reduces the infections that they get, whether it's a sort of parasitic type thing because they're unpleasant for the parasites to deal with, or it reduces the sort of viral infection, bacterial infection of plants. So that's a nice hypothesis, but again, it's difficult to know for sure if that's something that is exploitable. But it's noticeable that I've seen a couple of publications in the last 3 or 4 months, I think, where people have anticipated the potential for particular cannabinoids and the low abundance cannabinoids as having properties which might be exploited in that way. So that's interesting, and certainly something that I think people might well pursue. Some of the problems that you might anticipate is that a lot of these low abundance cannabinoids are difficult to isolate from plant sources. Whether they can be generated chemically in sufficient quantities to make them useful is a question. And that's another one of the problems that we have in the sort of translational area, where it's possible to get even some of the more abundant plant cannabinoids in quantities that you can do a small clinical trial with, but you would want tons of the stuff to make it, literally tons of the stuff, to make it something that's viable as a drug entity. So that sort of scaling up process is challenging. So it'd be interesting to see how that might translate. So I think that really is kind of an interesting area. It's not a particularly central area of mine to focus on, but it's one of those areas that you look at and you think, well, I'm really glad somebody started that, and it'd be interesting to see how far it goes.
Yeah, following intently.
Mm.
What areas? I mean, obviously that's one of them. But what other areas are you particularly sort of excited about and are watching sort of intently then, in terms of cannabinoids?
Well, so for me, I kind of, to a certain extent, I differentiate between the endocannabinoid side, because that really is very few of the plant-based cannabinoids, and the other plant metabolites. So one of the things I think is really interesting that has made some headway is the use of CBD for things like anxiety, whether that's in a PTSD type scenario or a generalized anxiety disorder. For sleep disorders, I think that's kind of an interesting one, and that may have an impact in many other areas, because we know that there's disturbances in sleep, and almost everybody has a depressive disorder. You know, the benefits of sleep are found with people who have chronic pain. So even though CBD may not necessarily have a direct impact on other issues, the reduction in anxiety, what we hope will turn out to be positive benefits in other areas like sleep, could well translate to beneficial effects in people with more indirect disorders. If that makes sense.
That makes a lot of sense, I think.
Yeah. So I mean, one of the things to with medical students in particular, one of the things we try and get across is, yes, we teach a lot of what we teach on the basis of a disease, but they also have to look at the whole individual. And as an individual, you'll have, yes, a prominent disease that brings you into their path, but you'll also have other things which may well be indirectly related to that. And so by treating one of those areas, you may actually reduce the symptoms in the primary area. One of the things I'm really interested in terms of the endocannabinoid system is whether it's possible to use it as a kind of surrogate for other issues. So being able to look at variation between individuals in the endocannabinoid system and identify somebody who's predisposed to a particular medical condition. And that requires a couple of things to be done. So interested in the way in which there's genetic variation in some of the receptors, some of the enzymes. We don't have an absolute capacity to be able to say, well, somebody with that genetic variation is going to have an increased risk of infection, inflammation, or something like that. So it's an association rather than a sort of causal relationship. But for me, one of the things that I think would be interesting is to understand why there is such a variability in responses to drugs in general, and particularly the sort of cannabinoid area. Because we kind of accept that, people are very accepting that, okay, the drug worked for you, but it doesn't work for me, and we don't know why. We're about the same size, we're the same sex, we're the same age, but why does it work for you, not for me? And that's also one of the big things in the sort of cannabis related medicine area. If you talk to practitioners in other parts of the world where there's a lot more experience of the use of cannabis-based medicines, that is their day-to-day observation, that they have people who come into their clinics and they say, okay, we're going to start you on this because that is probably the least aggressive, if you like, medication, but we may well progress to this, this, and this. And you can have two people who come in on the same day with very similar symptoms and very similar observations, but their responses to those agents can be completely different. So why is there that variability? And if we had a way of pinning that down, the medicines would be more successful because we'd only treat those that we knew were going to respond. And this sort of thing goes on all the time because we know that there are ethnic differences in the way in which drugs are metabolized, for example. And so, you vary the dose depending on, in some cases, not all by any means, it's a few only, but you can vary the dose and mean that you get a better quality of response. So that's one of the kind of areas I think is really intriguing.
That's fascinating. And do you think that's going to come down, is going to be primarily a genetic thing, or do you think there's more to it than that?
Yeah, so in general, when we look at drugs, a major feature is variation in metabolism. And that does come down almost always to genetic variation. But because humans are complex things with 20,000 genes, it's rarely a single gene. It's variations in multiple genes that kind of come together and so lead to increased or decreased susceptibility and the benefit that can be gained. So a large part of that is going to be genetic, but it may be difficult genetics rather than, yes, this one marker tells us that we can give this dose. But there will also be some environmental elements as well in terms of combinations of things. So, for instance, we know that going back to cannabidiol, that one of the things it does is it changes the metabolism of clobazam, which is a drug that's also used to treat epilepsy. So is part of the beneficial effect of CBD in treating epilepsy because it increases the amount of clobazam that hangs around. And then a kind of second, more philosophical question is, well, does it actually matter how it does what it does if it's beneficial? And you and I might have different opinions because I want to pick apart the molecular mechanisms and understand what goes on there. If I were a parent or a patient, I would not worry because the outcome is the most important thing.
I think I sit firmly in the middle where, and having been a patient and now working on the more pharmacy side of it, I certainly can appreciate both points of view, and it's it's no understatement to say I'm probably a bit conflicted there. I want to understand things fully. I want to understand the implications for patients for the future, but at the same time, I know that there are a lot of people who are suffering right now and who need that relief. So there's certainly a dichotomy there, and I guess the bottom line is there's a lot of work to be done. But also, I remember a lot of what you've mentioned previously is that actually the reality is that these compounds are relatively safe. So, I mean, we could be doing the research while enabling the access and hit two birds with one stone, or is that, am I dreaming here? Am I creating a scenario?
No, I think so. The history to date has been a positive one in terms of safety, but that doesn't mean as we go to higher doses of isolates that we wouldn't start to see damaging effects. And I think, going back to the mental health issues, I think that's definitely something that needs to be monitored. Not that wouldn't go on with any sort of drug exposure anyway, but it is something to be cautious about and to look into. The extended history of interactions with cannabis and man tells us that there's a tolerance there.
I only had isolates recently, really. So.
Yeah, so the sort of higher doses, more chronic exposure, that's a more recent thing. And the manipulation of the plant, which has always gone on. One of the sort of areas of contention when one talks about the plant is how many species there are. And it may be an entirely artificial thing in that the cultivation in different parts of the world has led to the botanical differences, and in reality there's just a single species with lots of different kind of subspecies.
Yeah.
And that sort of thing comes from around about 3,000 years of and probably longer, of human direction of plant growth and exploitation.
The breeding, essentially, I often compare it to dogs and how we've bred dogs for all these different, and essentially it's dogs are dogs, it's a single species, but there's lots of different, I mean, I'm not an expert in dogs, but
yeah, no, I think that is a possibility, which is not to say that there isn't a value to trying to identify chemovars, cultivars, strains, which may have different profiles. But it's really difficult to have the sort of botanical and external characteristics and compare them with genetic and metabolites, objective measures, and see a consistency about that.
It starts to become too complex, really, doesn't it? There's too many variables.
Yeah, and again, there'll be people who will ignore the sort of quantitative scientific element and say, well, what works for me is sativa during the day and indica at night. And if they're getting that on a regular basis, I guess that's up to the individual to identify and decide.
Okay, well, I suppose if I can ask you just one last question, and it's probably going to be the most ignorant question of the whole podcast from my point of view, but if you can, and perhaps a completely unanswerable one, but if you could give everyone watching an idea, I guess, of where we are in terms of our general understanding of the endocannabinoid system and I guess its impact on our health. Are we, and perhaps we can compare it to like a life cycle. Are we still in our infancy here? Are we approaching middle age, old age? Where are we?
Yeah.
I mean, it's a horrible question, I know, but
so it's the sort of thing that will be easier to identify in 10 years' time. But we're certainly not at the end. There's still lots of stuff that's going on. Partly because the molecules that we're looking at are so flexible in a sort of biochemical manner, and that we're finding that slight metabolic changes in these molecules produces something which is maybe not an endocannabinoid, but it's active at another target. And there's this idea that the metabolism in the body is really a miser, and so doesn't produce metabolites without some purpose. And purpose is really the wrong way to look at things, because whatever is there is there. But one sort of bit of philosophy of science would suggest that, okay, if they're producing these things and they're having these effects, then there's a reason for that. And so what we're identifying is it's not the simple issue that the endocannabinoids are just an anandamide and 2-lactone glycerol. There's a whole bunch of these and other analogs which are maybe not active at the cannabinoid receptors, but active at other targets. And so the metabolic processes that produce endocannabinoids and change them also change these other agents. And so what we're getting is a kind of metabolic chart, which when I first started was pretty linear. This agent produced an anandamide, and an anandamide acted at the CB1 and CB2 receptors and was metabolized by fatty acid amide hydrolase. Very quickly, that got expanded and expanded and expanded. And so now we have an incredibly complicated network of the synthesis of these endocannabinoids, the transformation of them into other bioactive molecules, which act at a huge range of other targets. And so, we've got a really subtle, complicated, devious, for want of a better word, frustrating network of things which are going on. That the way I work is I try and break things down into simple things and then go back and try and build up the more complicated. So the more complicated bit is getting really complicated, because these are not just different in terms of which different cells they work on, but they work on often small bits of the cell. So how do they then get from where they're made to that small bit of the cell and then get metabolized? And so that the sort of, and the time factors of all of these things as well. So how do all these get integrated? And trying to build up a mathematical biophysical model of what all these things do it's too much for my brain, I'm afraid. But it really is one of the reasons that you kind of keep going, is because the complexity is really interesting and probably meaningful. So trying to understand the complexity is the challenge.
Brilliant. Well, this has all been incredibly interesting, and I hope it's been very meaningful for all our viewers as well. It certainly has for me. It's certainly been fascinating to hear your insights, and it's fantastic to know that there are people like you here in the United Kingdom and across the world who are, doing this research and putting this work in and really unpicking the endocannabinoid system fundamentally, but also all these different physiological actions and all the different things that the implications that might have for us as patients and as human beings. So thank you so much for joining us today, and thank you for being on the show. And thank you everyone out there for watching, and we'll see you very soon on another episode of Grow Conversations.